Okay, I'm showing 1 o'clock on my computer, so people are continuing to join. So um, let people in the room as they get signed up. Please keep yourself muted unless you're asking a question, so we can try and keep the amount of interference and feedback to a minimum. We are glad once again to have Heidi Hotvedt joining us. There's lots of new information out from the CDC as well as DHS. So I know she has lots of information to share with us. I'm monitoring the chat. My name's Brenda, and I should be at the top of your list of participants. So if you have something that you don't want to share with the whole group, you can message just me privately and I can ask your question as well. And with that, I will go ahead and turn it over to Heidi.
Thank you so much, Brenda, and thank you again for allowing me to be part of this presentation today and hopefully provide some updated guidance for all of you and answer any questions that arise. Just want to introduce myself. Some of you may know me. My name is Heidi Hotvedt, and I am the coordinator for Healthy Childcare Iowa. I'm also a childcare nurse consultant, and so I provide leadership for the childcare nurse consultant team across the state. We have childcare nurse consultants that cover all 99 of our counties. And I know that many of you already work with your nurse consultants, but I have the honor to kind of represent them and to help coordinate the program for the state for Iowa Department of Public Health. So I just appreciate being on today. And I just want to say from the very beginning of this presentation is, you know, the last time I presented to your group, and I've been doing some other presentations across the state, things change. Things have been changing constantly, and we've had to be flexible, and that is really challenging. So I just want to say I appreciate everyone's flexibility during this time, because as things change with the Centers for Disease Control or with Iowa Department of Public Health or with DHS, we just need to be flexible and adaptable and trying to work through the situation. As we know, this virus the information has, and the data has shown us that there are different ways that are best practice guidance for when we have cases of COVID, and we've had increased cases across our state. So just want to thank you for that flexibility, because that's my new word. I think that all the time. Okay, I've just got to be flexible, because the minute I put out some email or guidance, it changes, and that's frustrating, but I've just decided that I have to go with it, and we're doing the best that we can with the information we have currently. So I'm going to go ahead and I'm going to share my screen and start that. I have a PowerPoint presentation, so just 1 second here. And hopefully everybody is seeing my screen. Let me start this from the beginning. If I can get a thumbs up from Brenda, can you see my screen okay? Great, thank you so much. So probably the first thing I'm gonna just go over is, if you think or know you've tested positive, that you've had COVID-19 and you're having symptoms. So I feel like this is the common question that I'm getting over and over. And I just want to talk about isolation and our isolation guidance. So, like I said, things change rapidly, so this could change, but this is what we currently, have for information. So if you have a child that, a parent that calls in and says, okay, my child just was diagnosed with COVID-19, or we think our child maybe was exposed and we're concerned that that they have COVID-19 or they have symptoms of COVID-19, we are following the CDC isolation rule. So our current guidance, and you'll see on here that there's actually a couple things that I just want to talk about, but the CDC has an isolation guidance rule. And at one time it was called a 10-3 rule, which was 10 days and 3 days. For free. And now they've just updated their guidance that it's actually 10 and 1. 10, and then 24 hours fever free. So, but our current document on the Iowa Department of Public Health website and DHS, our combined guidance document, still has the 10-3 rule. So I will just say that we know that that is a discrepancy from what the CDC guidance is, and so it is your policy, but we want to make sure that you're following current guidance. And I'm sure, as you realize, that sometimes guidance documents, when they change frequently, that it does take a little bit of time for our guidance documents to be updated. So I don't know if you've kind of seen that pattern, but it kind of seems like it always takes a little bit of time, usually a week. So I was kind of anticipating that our guidance would be updated fairly soon. And then I did receive an email that the guidance is being in the process. So it's a little bit of a process, but just so you know, so I just kind of put the 24 to 72 hours in, fever free without fever reducing medicine. But we really are sticking with that 10-day rule of they need to be symptom free. And that is very challenging for providers because, you know, they want staff to come back sooner. They want children to be able to be in care. But that is our current guidance document. Now, I know I just had an email. I just answered an email just a minute ago before we got on. And it was, you know, what do we do when a physician says, oh, we think the child has this, or the child has been diagnosed with this. And so they don't test the child, and but they have symptoms of COVID, and the child's not tested. So we really don't know. Yes, they might have, you know, a respiratory infection going on. Maybe they have just an upper respiratory infection, like a lot of kids get, where they get a cold and then they get a cough and then they end up with a sinusitis, or they get kind of a rhinitis and they have some cruddy, you know, discharge from their nose. And so then the doctor's like, oh, you know, it's probably this. But we really, at this time, and I'm going to say that again, at this time, we don't know that it's not also COVID. And so unless they're tested, we don't have that information. So best practice would be to have that child, because they're ill. And I know in the past we would have had that child allowed back into care within 24 hours from their antibiotics being prescribed, or if a doctor's note had written that they could be back in care. But to safeguard your business and other children in care, having them out for 10 days is really best practice. And that's the current guidance. So that can be challenging, I know, for families, but that is our current recommendations. And I would just say that you're really trying to safeguard the rest of the staff and the children in your care when you follow those best practice guidance. That may change. I think as we're getting more information from other states, I'm actually in a cohort group of other states. They're really looking at children that are having symptoms, and then, you know, because testing is so much more readily available now, which is great, they can really see, did the child have symptoms? Did they test positive? Or did the child have symptoms and they actually tested negative? And so I think when we get that more clear guidance from CDC, they might have some additional data that will allow us to say, okay, that might change our guidance in terms of, would we allow a child back in sooner into care, or a staff person back into care sooner? And I would say probably for staff, maybe not, probably maybe for children, I think, because that's the data that's been lacking for us. But like I said, we need to be flexible. Things are changing. And so we just want to let you know that that is the best practice guidance. And the reason is and I'll be honest with you, in our state, in Iowa, we have had children that have been back into care diagnosed with everything from, I know I've had consultation with ones where it's been, they were diagnosed with an ear infection, and the only symptoms they had was a fever, or they were diagnosed with strep throat and they had a fever and a sore throat, or they've been diagnosed with something that was upper respiratory, and so they were told it was a virus, and they you know, wanted to come back into care sooner. And we've had some situations where then all of a sudden there's additional cases are of that same illness, and then someone is tested and they're positive, and then when they actually test more of the group, they'll find out that maybe that first child that was allowed back into care was possibly the carrier of the COVID, because then they get a positive test result at a later date. And that has happened. So I think that's just to be following best practice guidance. I would just encourage you to look at your policies and to follow this. I will tell you, there is a lot of conversation around this because this is going to be very challenging for schools to follow. And I'm sure you've heard that. So that there is a lot of discussion going on in terms of, do they have some data to show that maybe we could not follow that guidance, or to have different guidance related to that 10 days. And it's really the 10 days. I would say the 24 hours to 72 hours fever free. I mean, we want kids to be fever free. They can't be in care if they have a fever. So, I mean, that's not as big a concern, I don't think. But the 10 days is definitely more of the concern. And then symptoms have improved. And I've had that question, well, what do we talk about when symptoms are improved? And it's, well, if they had, a sore throat, and they've had a sore throat for, more than the 10 days have passed, I mean, that's a problem, and they really should be evaluated, to see if there's anything else going on for that child. I know that's come up with, and sometimes when we say, well, symptoms have improved, I always go back to that same best practice guidance that we've had for a long time in care that follows the Caring for Our Children best practice. And that is, can the child comfortably participate in your day's activity without it interfering with their activity in childcare? So that's also a thing to think about. So what if the person, the staff, or the child tested positive but has no symptoms? That's another challenge, because they didn't have any symptoms, but they went in for a test result. We've had that happen quite a few. Actually, I've had a lot of consultation on this question. And so the CDC just recommends that if you continue to have no symptoms, it needs to be 10 days from when that have passed since the test. So the test results came out, and then 10 days later they could return. Now, we have had some healthcare providers, they are wanting to do a negative test, and the CDC said, when testing is available, they might want to look for 2 negative tests. So that might be individually different depending on where that staff or the child has gone to, if they've gone to the Test Iowa site or they've been followed up with their physician. So there might be some changes on that, but definitely we want to have that 10 days have passed since the test. And then, of course, if the person started developing symptoms during that 10-day period, we would go back to, no, you tested positive and now you have symptoms. So we want to go back to that guidance where they're going to need to be fever-free and all that. So that's just some basic stuff about isolation. And the reason I'm bringing isolation in first in my presentation is because the next thing we're going to talk about is really the case reporting and outbreak scenarios. So I do want to talk about that. And I thought, so here you have symptoms of a positive case or no symptoms of a positive case, but we know we have a positive case. And so the guidance document that's on the Department of Human Services website is very clear about case reporting and outbreak guidance. And we definitely need to continue to follow that until that's changed or updated. But if there was a confirmed positive case, that you're definitely working with your DHS person. That's the first person you're going to need to report to. You're also going to report to work with your child care nurse consultant and collaborate. And that's for just one case. Now, if you have 3 or more confirmed cases, and sometimes you'll have one case, that starts maybe, like on Wednesday, you get a positive case. And so you're looking at that, what, am I closing one room? Am I going to quarantine just that group of kids? Who was their close contacts? All of those things. But sometimes, and I had this happen just the other day, actually Friday, there was 3 positive cases in a program. And then now they have an additional positive case. So it's like, as people are being told that they've been exposed and then they go in for testing, then you end up sometimes with more positive cases. And so we look at a 14-day period of those confirmed cases for outbreak reporting if it's 3 or more. And those are 3 or more of not of the same family. So if it's 2 siblings and 1 staff, that does not count as 3. That would count as you're at 2, because you're 2 children that live in the same household. They're under the same household contact, so we don't count them as into that outbreak number. So it's 3 or more confirmed positive COVID cases in staff or children that are not of the same household. And then once there's 3 or more, then I know you've already, if there was 1, you would have already been talking with DHS and you would have already been talking with your local nurse consultant. But with the 3 or more, then you're going to want to reach out to your DHS person, licensing consultant, to tell them that you have now 3 cases that are confirmed. And then you'll also work with me. So we're tracking those, and I think we've been tracking for over a month, and I think total we've had across the state, I think we were at 10. I should have looked at that today. So I mean, I was thinking we would have more than that, to be honest with you. I mean, we've had a lot of single confirmed cases, but the 3 or more outbreak status for the last month, we're at about less than a dozen of those programs that have had that reporting. So you'll be, like I said, reporting to DHS and then collaborating with the local nurse consultant as well as me if there's 3 or more. And then really, letting your staff and your families know that they need to quarantine for 14 days. So that 14-day quarantine is still the current guidance for CDC. And the CDC actually put the website on here. The CDC has these new quarantine scenarios, and they have the calendar on there. So it's like, okay, so how do you count out your 14 days, which you'd think would be simple, but there's a lot of little discrepancies on that. So they actually have a couple different scenarios to kind of walk people through them. I always bring my calendar out because I'll say we always look at the 14 days, but we look at sometimes it's like, well, the last date they worked was this day, and this is when they were, this is the kids that they were with that day and the 2 days prior, because we're looking at 48 hours prior. And so there's a lot of kind of little nuances about 14 days quarantine. So we want to make sure that we're counting that out on the calendar, which is what I do. But they actually have scenarios on the website, which I think is really helpful. So just so you know that.
Heidi, we do have a couple questions.
Sure.
I should have let you know too, we've got a NAC credential course going on. So we actually have 1 participant, it looks like on the screen, but there's actually 13 of them in the room.
Oh, okay.
They sent me a question. It said, can you address, I think it was referring to your previous slide about the symptoms, about children that are teething or with allergies.
Well, that's, really challenging. I will tell you that with teething, a child may teeth and may have a low grade temp, and we always look at the temperature guidelines are 100.4 or higher. So, I know that there's a lot of times family will say, well, they're just teething, but they have 101 temp. And I will tell you, as a nurse and worked in pediatrics, teething is usually a low grade temp, 99, low grade. Once we start getting into the 100-degree temp and above, I'm always suspicious it's something else, because usually most of the time teething is low grade, and 100.4 is not considered low grade temperature. So I would kind of go back to that with teething. Now, this is the challenge. So I'll just go through the list of symptoms real quick, but it's, as we know, anyone can have mild to severe, symptoms. And, we're talking fever, chills, cough, shortness of breath, fatigue, muscle aches, headaches, loss of taste or smell. Now, I'm going to tell you, an infant could not tell you that. A toddler who's teething cannot say, well, these things taste funny, or I can't taste these. You probably will not know that symptom. Sore throat. A lot of times we don't know if a child has a sore throat, if they're still eating fine. Now, if they're not eating well, then we can, maybe think that they might have something else going on. But so I think some of these, and congestion and runny nose, very mild type symptoms that it would be very challenging to say, is it teething? Is it something else going on? But if the child's not having any other symptoms, and they actually, you can usually tell when they're teething because they do have, kind of that redness of the gum and, some of those other symptoms. They might be drooling a lot. So if it's a low grade temp and they're teething, that they do not have the symptoms listed in the COVID-19 guidance. In terms of allergies, if the child has an allergy action plan and that is the norm for that child, so the norm for that child is to have a runny nose. And we know this time of year, especially, and in the spring, there is a lot of allergies and kids that have allergies, seasonal allergies. So if they have a care plan and that's documented, and if they don't have a care plan, but you know that they have allergies or that's what the parent tells you, then I would recommend that you have a care plan put in place, and that would be something the doctor would be signing that states that the child has allergies. And so then you're looking at the normal behavior for that child. Does the child normally have a runny nose this time of year because of seasonal allergies, and they're taking a medication for that, or they're being treated for that? So I think that might help to answer that question.
I think that does answer it.
Okay.
And you've got 3 more that have come in, so I'll just go in the order that I got them.
Okay.
Question is, can you address what happens when there's a positive case in the home, but the staff/child tests negative?
Well, so if a child is in a household and their parent tests positive, then CDC recommendation, I guess I should go with CDC recommendation, is that if you are exposed to a positive case, that you should be quarantined for 14 days. Now, our CDC, our IDPH guidance says that if a child should stay home if their parent is ill. They really don't go into those specifics. So I always go back to kind of that, here's our overall guidance for that. When you're, a person is in your household contact is positive, then following the CDC is that you would be quarantining, because you're kind of looking to see if you're going to have a possible COVID symptoms. Now, if you test negative, just because you test negative one day doesn't mean the next day you couldn't be positive. So there's definitely, I know, and it depends on when you're tested, and then it also is that, if you're around somebody that is COVID positive, you're at that risk that you're going to possibly develop symptoms. So there are some guidance documents or guidance around that if you are living in the same household with somebody that is COVID positive, even though they test negative. So general overall guidance would be that there be quarantined for 14 days. But if you tested negative, that's the only way that's going to change for that, shortening that time period, is if, say, today you test negative and then 2 days later the child is retested and they test positive, then it would be 10 days from that positive case. So that might shorten that 14 days, possibly. Chances are it's going to be probably about 14 days still, but just be aware of that. And I know that there has been some discussion about that guidance, so that could change, but that's what we currently have.
Okay. And the person who asked that question added also that it was it and that they are asymptomatic. But from what you just said, that doesn't matter. If they're living in the same household with somebody who's tested positive, even though they tested negative, that could change in a day. So
correct. And that's
going to get tested every day.
Yeah, that's the CDC guidance. And like I said, if we refer to the DHS IDPH guidance, it would say that, we're really just looking at parents, or, like if the child is living in the household and it's the parent that is positive, they are not talking about or is ill. They said that then the child should be out for that because that parent is ill. I know we have a lot of questions. Well, what happens if it's a sibling that's ill? And we really don't have anything with DHS IDPH that addresses that specifically, partly because usually siblings are not caring for other children. It's the parent that's caring for the child. So of course that's a closer contact. And I was actually, my next slide, we're going to be talking about closer contact, so you guys can understand that. But every home situation is different. Every family situation is different. And so I think it's really important to get those specifics and then work with your local nurse consultant to work through those, because there may be a situation that the recommendation would be that child be out of care for that 14 days.
Yeah, I think there'd be lots of nuances with each.
Oh, very, yeah. I mean, we have the general, but it definitely, there's a lot of nuances. Yeah.
Okay, the next question is, what is the difference between the isolation for 10 days and the quarantine for 14 days?
Well, the reason for that is because if you're isolating, it's because you've either tested positive or you have symptoms. And so because we always look at symptoms starting usually 48 hours prior to a person testing positive, by the time they have 48 hours prior to the test, they test and they get the test results back, they are in active COVID symptoms. And so 14 days is because we're looking at that period of time from when they could potentially start having symptoms. But if they've tested positive, then they look at the 10 days after, because that period of time has already elapsed from when the beginning of their exposure would have happened, which would have been 48 hours prior to symptoms. So that's why it's a shorter period of time.
That makes sense. Last question that we have so far is,
Mhm.
is there a recommendation for how many symptoms a child or staff should have before they isolate?
The symptoms, we just really go off of the CDC list right now, and currently the CDC does not say a grouping of symptoms or anything like that. That could change. I know some other states are looking at that, so I just want to tell you that there are some other states that are looking at grouping of symptoms, and that might be something that could possibly change. So just be aware of that. But right now, it's any symptom. I'm sorry, any symptoms on the COVID symptom list. I should clarify that. So I'll go ahead. I'm going to talk a little bit about close contact, because that's something that seems to kind of come up a little bit. So when we are thinking about, okay, who do we need to, so a child tests positive or a staff tests positive in a particular room. And so you look at who are the close contacts for that child or staff. And so that's COVID-19 close contact definition from the CDC is that anyone who is within 6 feet of the infected person for at least 15 minutes. And it starts from 48 hours before the person began feeling sick until the time that the person was isolated. So if you have a staff person that, was working in, say, the infant room on Wednesday, but they were in the toddler room on Tuesday and they were in the school age room on Monday, you're looking at the school age room, the toddler room, and the infant room, and any of those close contacts, staff and children in those rooms. So that's that 6 feet. And we know that it's really hard to not be within 6 feet of an infected person for more than 15 minutes if you're in the same classroom. But I get the question a lot, like, well, what if they pass each other in the hall or they're using the same bathroom? So I get those kinds of questions. But it's really that, 6 feet within 15 minutes, which is quite a long time, even if you were in, passing in a hallway or whatever. Just really encouraging people to not be within 6 feet of individuals if they can, when they're in those mixed kind of situation, and overall not to mix groups. But I do know that there's some mixing. Sometimes that, happens where you're sharing the same restrooms or you're sharing the same space in terms of the hallway and those kinds of situations. It almost seems like a dance, when you're out and about and you're in, in places. I actually, was somewhere that was kind of crowded the other day, and had to be there. It wasn't really what I wanted to do, but I had to be where I was at, and I had a cloth face covering on, but it was really challenging to be 6 feet away from people because of kind of the concentration of the group of people that I was where I was at. So I think it's really important that we take protection. But and I've had this question too. Well, what if the close contact? What if everybody was wearing masks? And in terms of close contact, even if they had masks on, they still would be considered a close contact right now, even if they were having a mask, because the mask offers some protection, but we do know that, in the hospital setting, they wouldn't be a close contact if they had an N95 mask and a shield on, because that's what they're wearing to protect them from getting, any kind of exposure. But in the real world, we're wearing cloth face coverings, which offer some protection, which are great, but it definitely doesn't mean that the person couldn't have potentially had an exposure. So we're going to be looking at that close contact definition as it currently stands. And that definition is on the CDC website if you look for that, and it's actually under the frequently asked questions. That's a common question that gets asked by the CDC. So that's on that website. And then this is just a little bit of a review. I know we talked about this before, but I just thought I would leave this slide up here as really, we still have the CDC guidance for childcare programs that remain open. And they added some additional things about health checks and temperature monitoring. So that's really helpful to just kind of go back and read that updated, the CDC guidance for childcare programs that remain open. They have some really great information in there about, everything from, do we have to disinfect our, sand out in the playground to, how do we do a temperature monitoring, or what do we do if we have pending tests, for a staff person. So there's a lot of information on there. And I would recommend that you refer back to that frequently, just if you have any questions, but also, reach out to your nurse consultant. They can walk you through. Just a few things I want to kind of go through is, I get this question a lot. Children or staff with illness or pending COVID test. If they have a pending COVID test, if they're ill, they're not supposed to be in care. We know that. That hasn't changed. DHS has been very clear. They don't really care. Children should not be in care. Staff should not be in care if they're ill. But if they're pending a COVID test, they have to be excluded. You should make sure that they do not return until that COVID test comes back. And then you'll take it under, just determine if they can even come back or they need to be excluded for that 14 days. So then that gives you some additional information. That has happened in our state where we've had pending tests and children are in care, or pending tests from staff. And, and that's the thing. A lot of times they're asymptomatic. So they're meeting all the other guidelines. They're not, they don't have a fever. They're, they're not having any other symptoms. They're just having this pending COVID test. So they come to care to work, a staff person coming to work or a child coming into care, because it's just a pending. But we need to have them exclude because we don't know what that test result is going to come back as. So we need to make sure. The social distancing strategies, like I was saying, it's challenging, but I would say avoid mixing groups and staff, and as well as you can in your program to avoid floating staff. Floating staff is probably the biggest challenge that I've run across when working with programs that have had positive cases. Because of the staff person, we're looking at that 48 hours. So if you're having that staff person floating to all those different rooms, that's an exposure, and you're going to have to close those rooms. Or I shouldn't say close those rooms. You're going to have to exclude all those children and staff in those rooms. So what happens is those rooms all get closed. That's the result, because you have no staff that can be in those rooms. So even if you have children that are maybe on opposite days or don't come as frequently, or they were on vacation those days, chances are they're not going to be there because you've mixed that positive floater staff with other staff. And so then now you're having challenges with meeting ratios. So just that would be my overall recommendation for you, is to not have that floating staff. And then the other thing that I know is a lot of times some programs have where the staff all kind of meet maybe near the office or maybe at the beginning of the day, and they're all kind of in the same location. And if you're doing that, they need to be 6 feet away from each other. You need to be in a space big enough that allows it, or don't do it at all. Communicate differently, and that's challenging, I know, but when you're mixing a whole group of staff, or they're all eating in the break room together, or they're all together in a location for a meeting, and they aren't 6 feet away from each other, their risk definitely goes up. So that's my other comment on that. And then the cleaning and disinfecting your facility when someone's been sick, that's just a great document on the CDC website. So I would just refer back to that also, because that's a lot of questions we get about that in terms of, what do I need to do now? Because we've had a positive case. The next thing I was going to go into some other common questions that have come up recently, unless there's any questions. Brenda, do we have any questions that have come through?
We do.
Okay.
Um,
I'll go back to that previous slide then. Okay, go ahead.
Okay. Yeah, this one says, if person A knows the day they were last exposed to a person who tests positive and that person tests negative and remains asymptomatic, does that person A isolate for 10 days from when they were tested or 14 days from the date of when they were last around the person?
Oh, wow. I would have to say that is a little complicated, and we would have to sit down with a calendar and figure that out. So I'm not even going to try that one right off. I would literally need to pull my calendar out, and I would say, okay, when was the last person in care? When did they have symptoms? How were they exposed? So when we have those unique situations or those, I mean, it's challenging. I pulled the calendar up and we counted out. So sorry, I can't fix that one.
That's okay. And I believe I know the answer to this one, but I'll let you answer. That it's the 15 minutes is cumulative during an 8-hour period. Is that correct?
Basically, it's 15 minutes at a time within 6 feet of that person. So if you're working, if you're doing short little, you're still in that person's space. So I would say to avoid it, to be at all, because is it 10 minutes? Is it 2 minutes? Is it how much exposure have you had with that person? So I would just say, in general, if you're within 6 feet of a person and it's been 15 minutes of time. Now, like I said, when you're passing in the hallway or you're in the bathroom area, they're really not saying that's a close contact, but we're saying those close contacts are really those children and staff that are in that group together and have been around each other and have not been able to maintain social distancing at that 6 feet. And I would say in general, that's very difficult to do in care.
Okay, and the last question that's been put in so far, well, change that, I just got another. Okay. The next question, what about playground equipment that is shared by different age groups? Do items need to be sanitized between groups?
Actually, there's some really great information on that CDC guidance, that cleaning and disinfecting guidance, and then the programs that remain open specifically around cleaning of equipment. They really say to not do mass disinfecting in the playground outdoor environment, that it's not a really good use of disinfecting products, but that the high touch areas. And I'm going to actually, this is on my slide, I think this is on my next slide, actually, we're going to talk about it, but the National Program for Playground Safety, I don't know if most of you are aware of this, but they are based out of University of Northern Iowa, so not too far from you. And NPPS has some great resources specifically for COVID. So if you haven't checked out their website, I'm going to encourage you to check out their website because they have some great information for the outdoor environment. And they definitely address that disinfecting in the outdoor environment. So I think that might be helpful for you. And we're really looking at those high touch, high use areas. So, if you're doing an outdoor learning activity that's outdoor, maybe you're doing some science or you're doing something with nature and you're all at the picnic table and then the next group's going to come out, we would want to disinfect that table. So think about the areas where the kids are either handholds on the climbing structure, the kids are all touching those kinds of things, but not mass cleaning of all the areas in the playground, but definitely those high touch areas. And I think of like the slides, when kids climb into the slide too, like if they're going to go down the slide, they're touching all that at the top, and all the way down on those handholds. And so those are pretty easy that you could spray those down and disinfect them. Put your disinfectant down, on and let it air dry, for 5 minutes before you go out or whatever your dwell time is. Hopefully it's 5 minutes or less, but I know right now that's challenging sometimes with some of our products, but say it's 10 minutes just so that you have your dwell time out there. It can, and then it'll air dry and then you'll be ready to go. So.
Okay, this one was in regards to your comment about the staffing and not having floating staff. What is the recommendation if there is someone that takes vacation and having staff coverage in that room? Is it recommended they just close that room if staffs take off, or
Oh, for having a different, no, I think, you know, I mean, you're going to have that happen. And so you're just going to need to have that staff person be in that room, knowing that if whoever is covering for that person while they're gone, you know, if they test positive, that might expose that whole room. When I think floating staff, I'm thinking more, they're in this day, they care for the infants in this room, or you know, and they're only there for half of that day, and then they switch maybe after lunch and they go and help out in the school age room, or I think of floating staff where they're not really assigned a room, or they only do the beginning shift and the end shift. That's another one that's really, because you're exposing a whole group of kids that way. And I know that's challenging, but trying to figure out, okay, who could I have, you know, that are trying to keep those same groups together. And we know for developmental milestones and for children's best practice is that really to have that core caregiver that they're with, you know, for best social emotional attachment. You know, that's really best practice. So we're kind of going back to almost the best practice of what's best for the kids, but we know that it's challenging for programs to do that. But definitely that floating staff where they switch rooms a lot, you know, that's challenging. So if you have staff that maybe aren't assigned a specific room, maybe they're assigned a specific room for the whole week, you know, so we're not having them jump every day to a different location. So.
okay. And then last question, I'm not sure we have an answer on. They're asking how long the virus can survive on surfaces.
You know, we don't really have a clear picture on that, but we do know that the CDC has said that, you know, to avoid going in a classroom within the first 24 hours, to ventilate the area, but to not do any disinfecting until after that 24-hour period. So we know for sure that there's active, you know, COVID virus that you possibly could have an exposure to on surfaces, you know, if it was a positive case in a room. So we know that guidance is out there. I have heard everything from 24 to 72 hours. I've heard even longer than that. So I think the general, I know the one thing on the CDC, and I still believe it's on there, that if it's been more than 7 days, the virus, there's no additional cleaning, disinfecting that needs to happen because the virus would be gone. So I do know that's on the CDC, and if one of my nurse consultants on the group, if that's changed, that's one thing I did not look up today, because I've got every Monday morning, that's what I do, is I go through and I see to check to see if anything has been updated, because that usually seems to happen on Fridays. So correct me if I'm wrong on that.
There are some more questions, but I want to make sure we give you enough time to get through your slides. So
yeah, I have a couple more, and if we
okay.
could go through those and then maybe take those questions at the end, if that's okay.
Yep, that'll be great.
Great. Yeah, we're getting close to time here. So just want to talk about some common questions that I keep getting about cloth face coverings and face shields. So just, you know, in general, I would say that for cloth face coverings, you know, programs may consider having staff and older children wear them. Definitely, if you haven't already started this, is to work on possibly school age care kids. You know, if you're trying to figure out how to start slow, if you're not having children wear face coverings, is to make sure that you're really talking with your school district, because if the school district, and I would say many, if not most, school districts are considering or are talking about that they're going to require masks to be worn for school age kids. So, you know, something to think about. It'd be great if you wanted to introduce that to them, and maybe you're already doing that, but having a system in place to do cloth face coverings. But there's a lot of things to kind of consider. You know, if they're over the age of 2, they can have a cloth face covering. Under the age of 2, they cannot. So no toddler infant should be wearing them. That, you know, children are going to need to remove them during meals and snacks, and when they're drinking water to stay hydrated. So we want to make sure that you have a place that they can put those cloth face coverings, or if you're going to switch them out at mealtime, so they might have a new one for the second half of the day, you know, maybe switching at lunch. Masks should not be worn while napping. That's still in the guidance. You know, I've heard anything for storage, you know, either having them in a plastic, like little Tupperware kind of thing where they put them in that, or in their cubby, or if they put them in a Ziploc bag or something like that. So that's a good thing. Are you going to provide them? Are the parents going to provide them? Those are some of the questions that I know keep coming up. We know that if they get damp or wet, they need to be replaced. So they're going to need a couple for the day for sure. Hand washing prior to putting the mask on, and then after removal. And then who's going to launder them? Is it going to be at school or at childcare? Is it going to be sent with them, and the families are going to do that? And you know, if you're not going to, I mean, that's the big concern. I kept thinking, well, if you know, don't launder them on site, how do you know that when they're coming into care that it's, you know, it's a new clean one? So, you know, those are all things to consider. Definitely children under age 2 should not wear them. And then the question I've had is, how about we just go with face shields? And the CDC guidance document currently says that face shields alone, they really don't have the data to say, do they protect? There are some different styles of face shields that I know that in a hospital setting they use, and they're the kind that wrap around, or they're full shield, almost like a hood that goes over their face and covers both sides. But most of the shields that I've seen on the market, kind of available to the general public, do not have that style. So they're really, it's not known if the face shield would provide a benefit as a way to prevent the spray of respiratory particles. They're not recommending face shields to be used for general everyday activities. They're recommending cloth face coverings. There's a lot of updated information on the CDC about cloth face coverings, really helpful. Videos, everything, how to work with kids with cloth face coverings, laundering instructions, how to sew them yourself. You know, so there's a lot of emphasis on cloth face coverings. And I do know that there's been some questions of, well, should we do face shields for those younger kids, for those infants, because they can't wear a cloth face covering, and they're very clear that face shields for newborns and infants are not appropriate. That's really clear in the CDC guidance, and they should not be doing that. And then if they're a disposable type face shield, they would have to be thrown away, because there's no way to disinfect those. So I know that there's some face shields coming on the market. You may think about having cloth face coverings as well as face shields. I know there's been some questions of, if we go to a face shield, that would be, you know, better, so that at least, you know, children can see, you know, see the staff smile, see the staff's face, you know, it aids in communication. But the information from the CDC is really, they just do not have clarity if that's even a prevention for the COVID virus. So you have that information, and you can look that up on the CDC website. Hand sanitizers with methanol, that was a FDA alert. The Food and Drug Administration sent an alert out. I think that's been maybe 10 days ago. I did add that to our Healthy Childcare Iowa COVID section on our website. So if you want to read that alert or go directly to that alert, the link's on there. I put that on there because we have had some hand sanitizers that were methanol based. And I know that they've had them. I mean, it's been found in Iowa. There's a list on the FDA alert website in terms of the products, the name of the product, and where they were, you know, what company sold them, like if they were from whatever store. So you can go through and look at that. And just so you know, that on the Healthy Childcare Iowa website, we actually have a whole tab related to recalls. So it's recalls for toys, it's recalls for car seats and anything transportation wise, and we have recalls for the FDA for food and drugs. So if you haven't signed up for the alerts from those links on our tab, you can go to that one recall tab on our Healthy Childcare Iowa website, and you'll be able to get those alerts they'll come. You can just sign up for the listservs for those recalls, which I think is a great way to kind of keep up on this kind of information. Bleach solution recipes. I know there's a lot of different recipes out there, and I'm just going to be honest with you. Even the CDC has a recipe out there for bleach, several different places. And that's been really challenging for childcare because we know that there is no recipe for like general bleach. Bleach dilution we need to be following the label for disinfecting. We need to be following the guidance that's put out by the bleach manufacturer, because depending on the type of bleach you're using, it will be a different recipe. I shouldn't even say recipe, dilution, water to bleach ratio. So I know that that's confusing, and we actually, like I said, I'm in a cohort group of other childcare nurse consultants, health consultants across the United States. And one of our representatives from that group from California, she actually works with an epidemiologist and an environmentalist, and they wrote a letter to the CDC, a formal request to please take off recipes from the bleach solutions on the website because it's confusing. So make sure you're following the label for the mixing ratio and the dwell time specific for the bleach product that you are using, and that might change. If you go today and you buy this brand of bleach, and then tomorrow you're having to find a different brand because it's not available, follow the manufacturer instructions for that mixing ratio and the dwell time, because that's going to matter too. And then if you need help, please reach out to your local nurse consultants, because they're great at this. They can look that up. They can help you walk through that. So, sometimes you can spend hours trying to look that information up. Call your nurse consultant. She'll look it up. She'll be able to tell you right off the bat. So 70% alcohol for disinfecting. That's actually on the CDC website, that if you're not able to find your disinfecting solutions that you normally would use, and you're not able to find bleach, that 70% alcohol is effective for disinfecting. However, there's a lot of concerns for that for childcare. So I'm just going to say it is not best practice. I would not recommend it. And the reason I say that is because we know that alcohol-based solutions, so basically those 70% alcohol for disinfecting is usually 70% alcohol mixed with water. Or I even had a provider I know said that they would just bought 70% alcohol and they put it in a spray bottle so they could spray it for disinfecting. And we know that the label for 70% alcohol is that it should be kept out of reach of children. It's highly flammable. They have a caution that it causes eye irritation, can also cause skin irritation as well, but eye irritation is actually a caution on their label. And then there is a poison control concern, and that actually has come out from the Iowa Poison Control, stating that alcohol can be deadly for children, and children, can become it affects their nervous system. They can become drowsy, they can have seizures, coma, and even death. So even if a child smells a small amount of alcohol, that they recommend that you would, call the Iowa Poison Control Center. So that's very concerning that we would have a product, in childcare that would have those warnings on there compared to our other products like our normal list of disinfectants that we use or our bleach solutions. So reach out to your nurse consultant and maybe think of, maybe there's something else. And I will just tell you this, the Childcare Resource Referral has been great. I know Department of Human Services has given them some funding to be able to purchase supplies in bulk for providers. So please reach out to your CCR&R consultant if you're having a hard time finding disinfecting solutions, so they can help you with that. And like I said, the outdoor play environments, National Program for Playground Safety, they have a COVID site, or COVID tab on their website, and they have some great information for you on outdoor play environments and COVID. So I would recommend you do that. So I know some challenges sometimes finding or going to our website. So I'm actually going to pull up our website real quick just so you can see where things are at. But on the on our let me actually, I'm going to end this and I'm just going to go right to I'm going to stop sharing for just a minute and then share our website, okay? Okay, do I have a thumbs up that you're seeing our website now? Okay, great. So this is our Healthy Childcare Iowa website. And we have our childcare nurse consultant page. If you look at our tabs here on the left-hand side, if you need to find your consultant, you can click here and the PDF of the current map with their contact information is there. We have some child safety, some other tabs on the side. That tab where you can find drug recalls, the food and drug recalls, the Consumer Product Safety Commission toy recall list, that's under that tab. I'm just going to click on it and show you. So all of the recall pages are on here. So you can sign up for those listservs, which would be a great thing if you haven't done that before. And then under our printed products page, we have a COVID section, and I pretty much am updating this. I wouldn't say every week, but almost every week. So I know it's really challenging to find some of the CDC links. So I'm just keeping them kind of here. So it's easier for people to find them on our Healthy Childcare Hour website. So we have some information of those, like the CDC guidance for child care programs that remain open that I just talked about. There's some interim guidance in here that would also be helpful for those programs that maybe are reopening that have been closed for a while. Here's that alert for the Food and Drug Administration alert on the hand sanitizers with methanol. So that's right here. The case reporting and outbreak responsibilities for child care centers and homes. That's also here as well as the DHS has that on their website. So it's kind of in both places if you're looking for it. The CDC link for if you're disinfecting your facility because someone's sick, what to do if you're sick. The Test Iowa site's here, link is here, and then the quarantine information that includes the close contact scenarios, those ones I was talking about where it's a scenario and it actually has a calendar, that's right on that website, on our website here. And then some additional information from the Iowa Department of Public Health. They also are linking quite a bit of links to the CDC, but all of the guidance on that cloth face covering and those patterns and everything are on there. And then, of course, the CDC website, we have that link on here, and DHS and the CCR&R website, which has a lot of helpful information. I did add the first aid CPR AED course extension information on here, and that actually, I think they're going to be changing that a little bit. American Heart Association and the American Red Cross, some of them are back doing face-to-face trainings now, but they still have that extension of the CPR and first aid on their website. So that current document, it has some helpful information, and then, like I said, that might be updated. And I do know that that Department of Human Services, talk to your licensing consultant if you're having challenges with having your staff get their CPR first aid. And I think I already showed you kind of where the map is, so that's about it. We can go right into questions. I know we're very short of time. Oh, 2 minutes.
That's okay. It's not going to kick us off. So
okay.
We understand if some people have to get off at 2 o'clock, but we will continue the recording. There's no other meetings after this, so we can go over if we want to.
Great.
The questions that I have so far is, aside from all daycares, is the number of kids per room still at 10 if it is just an after school program that meets for a couple of hours?
From my understanding, the Department of Human Services, that's just that's a guideline. That is not a requirement for the 10, but it is best practice. And I know that the last I looked, CDC still was saying those small groups is best practice. And Department of Human Services hasn't taken that off of their guidance document at this time. So it's still in there, and it's really for all programs.
Okay. And then the next question says that they use a floater for breaks. Is that something we should not be doing? And would you suggest a whole extra staff for each room so that we don't have to bring someone new in for breaks?
Yeah, I would say that definitely puts yourself, that's a higher risk activity, is to have that floater for staff or for breaks. So, you know, however you can change your staffing so to eliminate that would be best practice, so that you're not you know, having a potential exposure from that floater coming into different classrooms. You know, I know it's very challenging, and that's where I would just say, you know, encourage you to reach out to your DHS licensing consultant and your CCR&R consultant, because I think they're so great about having, you know, helpful information and how other programs have maybe been able to go through that challenge. And so they could provide that additional guidance. And not to say that nurse consultants wouldn't be able to provide some additional, but I would say that's not their expertise. Ours is more really in the health and safety area, and ratios and kind of staff layout. And some of those things are really the expertise by the consultants, the CCR&R consultants and the DHS licensing consultants.
Okay. The next question, I think is referring to when you were talking about storing the masks that children are going to wear. She said have hooks that are well spaced. Can the children place them on the hooks while they're not wearing them? So I'm assuming her question is going to be about the distance between.
About how far they need to be. I know they shouldn't be touching. You know, I'd have to look that up. I haven't had that specific question. Or maybe I would refer you to the local nurse consultant that you work with to see, she could maybe look up that information if you wanted to know that for today. What I have heard is that they're putting them in their cubby. So if they're using a hook, they're actually hooking it into the cubby. I've heard that. And I know that some programs are doing either Ziploc bags, or they're doing plastic, you know, containers that they can run through, the kind of like little Tupperware containers that they can run through the dishwasher. So they're keeping those sanitation. That would be the thing if you're hanging them. I know the one case I was talking to, they were hanging them in their cubby, but they were definitely they were disinfecting their space using their disinfectant on that. So that might be a little challenging depending on how your hook system is.
Okay. The next question is, why is Iowa considered a hot spot?
I don't know. I'll just tell you, in this cohort group that I'm in, there's people from New York and the Carolinas and Arizona and some of the other states that are really hot spots. And they're like, how in the heck did Iowa end up on the hot spot? Because other states look at our numbers and think, wow, your numbers are so low compared to ours. I had that question actually just the other day. So yeah, I said, I don't know how we ended up on the hot spot. I think it's because there's not a mandate for masks. So I don't know that for fact.
Could be, and you know, just speculation too is they talk about numbers of cases, but since Iowa's population is smaller, sometimes our percentage affected is higher, and we don't really get that on the maps. It's all about numbers versus percentages. So
well, and I think the thing is too, Iowa has done a lot of testing. When you compare, I mean, when you look at that, we have tested, I think, of 1/3 of our population, I think, because I looked at that the other day. I mean, it's a lot. We have tested a lot compared to other states when you compare that. So we've, you know, we've had more positives because of that, probably.
Yeah.
Because we're testing.
That definitely could be. This comment says the tests in their area are taking 2 to 4 days to return from the rural clinics. They assume that they're sending them to a larger hospital lab to get results. Is there a rapid test families can get done, or a place families can go to get results faster?
I think, you know, I would just recommend going on the Test Iowa site too, because it seemed like I know some of the locations, they're kind of doing a faster test. It seemed like most of them were coming back within 2 days. I haven't really heard of like a rapid test that comes back quite quicker than that. You know, usually what I'm hearing is it's taken a couple days to get them back.
Okay, and the last question I see right now is to clarify, if a sibling of a child in the program tests positive and the provider will not test the child in the program, the child needs to be quarantined for 14 days.
So I'll reiterate that is not on the current DHS guidance. The current DHS guidance talks about a parent, because of course a parent is giving, is direct care. So, their close contact exposure from a parent to a child is, that they're close contact. A sibling, on the other hand, that's, if you would look at the CDC website, they do not differentiate between who that close contact is. They're just saying close contact, 6 feet, 15 minutes. So so I think you're going to have to really look at that, what you're going to put in your policy. If you're choosing to go above and beyond and look at that best practice guidance from the CDC, then that's what you could put that in your policy. But in terms of what DHS requirement says right now, it's parent.
Okay, and then the last thing I see in here is there any breakdown of the positive cases in the childcare age group, more the 0 to 12 or 0 to 13 versus the 0 to 17 years that's put out on the state?
I have not seen any data. I know they're collecting that data, so I would not be surprised if we are able to kind of look at that at a later date, at that data for those younger age groups. But what's published on the website right now is just that 0 to 17. And we know a lot of teenagers have tested positive, so that it's hard to really differentiate the child care range or age range. And so I do know they collect that data, and I think, we will see that someday. It just is not readily available right now.
Okay, one more came in. I have parents pressuring the teachers to wear masks, but not the preschool students. We have decided that everyone will wear masks or no one wears masks. What would you tell the parents pressuring just the teachers to wear masks?
I think there's a lot of back and, kind of different information about masks, but we do know that masks do provide some level of protection. And, I believe that many schools will be going to a requirement for masks. I'm not sure, in your local area, but I would reach out to your school districts if you have a contact to say, is that a requirement? Because then, to me, explaining that to parents that we are going to all wear masks, because that's going to be something that they're going to be seeing either their older siblings or their friends, in their neighborhood wearing masks, or they're going to see some of the kids that they know, through maybe if they are preschool age and they're going to be on a school site, or in a school location, they're going to see others wearing masks. And so I would say, being consistent, that will help with that comfort level for that child to start having that wearing those masks in the childcare setting, if they're of the age that they can wear a mask, but specifically for those preschoolers.
Sorry, I gotta unmute myself there.
That's fine.
That's the last question that I see in the chat box right now. So okay. I appreciate you staying on a little extra. If there are additional questions from anybody that's on today, feel free to send those. I'll put our general email address in the chat box.
And I'll stop sharing if you wanted to bring anything up. So.
That's okay. No, I don't. You can always email childcare@episervice.org, or if you still have the email from Constant Contact that you got today as a reminder, if you reply to that email, that comes right to me, and we can get any additional questions sent on to Heidi for her to ask. And as soon as we get the link to the recording, that will get posted on our YouTube channel, and I will send you an email with that link once it's posted. So thank you, Heidi, for all the directors that are on today. If you have any childcare groups with home providers in them, we are having the same presentation tonight at 7 o'clock for childcare homes in our region. So feel free to spread the word about that. And thanks everybody for joining us.
Thanks so much, Brenda, for having me on. Thanks
Thank you,
everybody
Heidi.
for your flexibility and the great job you're doing in Iowa with childcare. I appreciate it.